Boerhaave syndrome, named after the Dutch physician Herman Boerhaave, is a rare but potentially life-threatening condition characterized by spontaneous rupture of the esophagus. This condition often results from a sudden and forceful increase in intraluminal pressure during episodes of severe vomiting or retching. Boerhaave syndrome poses a significant medical challenge due to its elusive initial presentation and the potential for severe complications. Define Boerhaave syndrome. Boerhaave syndrome is defined as a transmural perforation of the esophagus, usually occurring in the distal part of the organ. The classic scenario involves the rupture of the left posterolateral aspect of the lower esophagus, just above the gastroesophageal junction. This syndrome is primarily associated with episodes of forceful vomiting, leading to a sudden and dramatic increase in intraluminal pressure. The increased pressure exceeds the tensile strength of the esophageal wall, resulting in a full-thickness tear. Epidemiology. Boerhaave syndrome is relatively rare, accounting for a small percentage of esophageal perforations. It is most commonly observed in middle-aged and elderly individuals, with a higher prevalence in men than women. The syndrome is frequently associated with heavy alcohol consumption and a history of chronic gastrointestinal disorders. Pathophysiology. The primary pathophysiological mechanism underlying Boerhaave syndrome is a sudden increase in intraluminal pressure within the esophagus. This can occur during intense episodes of vomiting, retching, or other forms of increased intra-abdominal pressure. The forceful contraction of the diaphragm and abdominal muscles against a closed glottis generates a substantial rise in intraluminal pressure, particularly in the lower esophagus. This increased pressure overwhelms the esophageal wall, resulting in a rupture. Clinical presentation. The clinical presentation of Boerhaave syndrome can be variable and may initially be deceptive. Patients often report a history of vigorous vomiting preceding the onset of symptoms. The cardinal manifestation is severe chest pain, typically located in the lower chest or upper abdomen, which may radiate to the back. Other common symptoms include dyspnea, subcutaneous emphysema, and hemodynamic instability. In severe cases, patients may present with signs of mediastinitis or sepsis. Diagnostic evaluation. Timely and accurate diagnosis of Boerhaave syndrome is critical for initiating appropriate management. Diagnostic modalities include imaging studies such as chest X-rays, contrast esophagography, and computed tomography (CT) scans. Contrast esophagography remains a valuable tool for detecting the presence and extent of esophageal perforation. Management. The management of Boerhaave syndrome necessitates a multidisciplinary approach involving surgical, medical, and critical care interventions. Early surgical intervention is the cornerstone of treatment, with the primary goal being the repair of the esophageal rupture. In cases where surgical repair is not immediately feasible, conservative measures such as broad-spectrum antibiotics, nutritional support, and close monitoring are initiated. Conclusion. Boerhaave syndrome represents a rare but serious condition that demands prompt recognition and intervention. A thorough understanding of its pathophysiology, clinical presentation, and diagnostic approach is essential for healthcare professionals. Timely surgical intervention remains crucial for optimizing patient outcomes and minimizing potential complications. As advances in diagnostic and therapeutic strategies continue, a comprehensive understanding of Boerhaave syndrome will contribute to improved patient care and outcomes.